ఎక్కడ పెట్టుకోవాలి? కింద పడిపోతే రవి వచ్చిందా? వస్తానదా? లాలేదు ఎక్కడ బెజావన్ చేస్తా. లాలేదు ఎక్కడ? ఓటీ ఇన్ఛార్జ్ ఎక్కడ? రామన్ ఒకసారి ఉందా ఇక్కడ? లాలేదు ఎక్కడ? ఉన్నాడా? ఏమో బాగానే ఉందా? కింద పడుతుందా? ఇక్కడ ఒకసారి మాకు ఓకే. All right, okay. You only came. All right, good, good. Willu, Merrill, Suchar Siv Jeshi Chapal Valak. You had breakfast?
Yes, sir.
Good.
IT Srinivas. Sir.
దూరం ఉండాలి. ఫస్ట్ టైం వచ్చినా వాడికి అరౌండ్ 3 feet అవే ఉండాలి. ఐటీ నుంచా? షీఈ్ రన్నింగ్ షోనా దివ్యానా? ఓకే, టెస్టింగ్ వస్తుందా? సో ఆన్ ఎప్పుడు ఆన్ అయిందా? ఓకే, ఇక్కడ చూపించింది టెస్ట్ చూద్దాం. Open your phone and the link, we'll send you a link. Live is going on YouTube.
Sure.
మన పీజీస్ అందరికి చెప్పిందా? అనస్థీషియా పీజీస్ వస్తుందా?
ఆడియో వస్తుందా?
వస్తుంది. ఓకే, ఇక్కడ పెట్టు. హలో, తీసుకురా ఇక్కడికి. కేర్ఫుల్, దూరమ్మా. లక్ష్మి వాడి దగ్గరికి వస్తాడు. ఇది ఫోకస్ అయ్యి. సో దిస్ ఈస్ Gopal Reddy, 70-year-old man with severe osteoarthritis of the right knee. As you can see, he had left knee replacement with us 9 years back. 9 weeks back, and he is doing extremely well. And other side, he got various deformities, severe osteoarthritic changes, both medial and lateral, as you can see. So knee replacement has become very common nowadays, and it's a common surgical procedure every orthopedic surgeon should know, and all trainees should be familiar with knee replacement, because coming days is going to be more common. As we know, last year around 5 lakh knee replacement were done in India. But there's more demand. There are so many crores of people waiting for knee replacement. So I will take you through basics of knee replacement, and probably you can leave your questions in the chat box. We will try to answer. So draping is important in a knee replacement, and you should supine position with foot support and thigh support, and the leg should stay 90 degrees on its own without any assistant. And of course, foot should be clean draped. It should be clean and draped and upside, and we use a cling film. And the landmarks would be tibial tuberosity, patellar ligament. కనిపిస్తుందా? చెక్ చేయండి సరే. ఎక్కడ? ఇక్కడ. ఓకే, కూల్. And this is the patella, and of course quadriceps. So those are the tibial tuberosity, patellar ligament, patella, quadriceps tendon. And the incision should be, it starts in the midline, middle of the patella, and slides onto the medial side of the tibial tuberosity, not on the tibial tuberosity, because most of our people kneel down and it forms a painful scar. So just go onto the medial nail. You should not go more than 2 to 3 fingers breadth below the tibial tuberosity, because there is saphenous nerve branch which will cause neuritis as well as. And I routinely use tourniquet with exsanguination. And when you suspect peripheral vascular disease, you do not exsanguinate, and any other conditions where vascularity is compromised, you don't exsanguinate. And most of the time we do with a tourniquet, but sometimes we use tourniquet only for cementing, especially in a peripheral vascular disease or any repairs around popliteal or thigh conditions which will prevent using a tourniquet. So knife please. Again I said that is the incision, so the important part is you should not dissect the planes. Forceps. And if you do hemostasis at this stage, easy later on, because we release the tourniquet and close the skin and the wound. Knife. So as you can see, I am not, that's a fibrous layer of the superficial fascia. Just go down there, little maybe more, identify the medial border of the patellar ligament. Generally you find a vessel there, and in the midline quadriceps tendon. So go through the quadriceps tendon, suction should be ready so that there will be effusion. You can see significant effusion into lot of fluid, and side of the is okay. Gopal Reddy garu baga aitundi operation. Okay. Chala arigipoyindi. So okay. Now extend it, try to evert the patella and light okay na కనిపిస్తుందా? దానికి నాకు మానిటర్ పెట్టేట్లు ఉండాలి, నేను చూసేటట్లు కూడా ఉంటే బెటర్ కదా. నెక్స్ట్ టైం బెటర్, isn't it? Monitor unte we'll see what's happening. So the exercise fat pad, what comes in the way. Okay, as you can see, lot of gone completely. So little. So this is important. Medial. We stopped releasing too much. Learn from robotic knee surgery. So we don't do too much of soft tissue release, or hardly release. But we need to expose the tibia anteriorly. So start off with diathermy, just proximal. This is the retinaculum. You don't release MCL, but go underneath it, and with the periosteum, just go underneath it. You don't release it, and you take the osteophytes from the medial side, okay, good, and use the, have to be careful. If you too much of pressure, MCL get damaged. And one on the side, one on the top. One more. Moments. Okay. Now as you can see, that is the PCL. So your entry is just anterior to the PCL, but osteophyte is there. You can't drill, you can drill directly, but it's better if you make it little rough, taking that osteophyte out. Okay, so now you will have a landmark and it doesn't slip. So expand him out and push it in, don't drill, especially in osteoporotics. What happens is you can penetrate.
Right 5, 9.
Right side,
5.
right 9 and 5 is the standard cut, but it's got little bit of flexion deformity, so probably I'll take a millimeter more.
11.
Okay, good, better. Good. Take it out. And again check it whether you're taking. So if it one tip is, if it is going just in the notch, that means you're not taking too much or too little, and you're taking reasonable amount. Sometimes you take too much, which will change the whole. Okay, now. Okay, good. Take it out. So that's a distal cut. We aim to take about 9 to 10 millimeters. Just to see whether it's a complete. Good. And always run the saw, make sure the distal part is cut properly. Good. Just take that piece off. Cut off. Coming in the way of visibility. It will come off later anyway. Okay. Now you take the bristow and just clear the area underneath so that your sizing becomes easy. And this is a sizer. This is a Freedom knee of Max Medical Company. Okay, push down. Little. Okay. So, important thing in this is the most important step in knee replacement. The size of the femur is very, very important because it changes the gaps. So, give me forceps. Zoom in చేయమను వస్తుందా ఎక్కడ కనిపిస్తుంది ఓహో దీంట్లో కనిపిస్తుందా వెరీ గుడ్ ఎక్సలెంట్ సో దిస్ షుడ్ బి ఫ్లాట్ కంప్లీట్లీ బోత్ ది జిగ్ అండ్ superiorly the stylus should be in the lateral ridge, just touching, and you can see it's coming, I think E, big size. If it comes in between, probably take the nearest one. This is anterior reference knee, so it doesn't change flexion gap, but it might notch if you're not being careful. E, size E. Last time also size E?
Yes, sir.
Okay. And anesthesia we do under spinal and femoral block. Take it out. That's the same picture coming there?
Yes, same YouTube channel.
Good. And again you check it. It's not overhanging and you're cutting not too much, not too little, and okay, you put the middle, good. Angel wing, again you check it so that you are not notching, because it is anterior referencing, so it's not notching. So it's coming little, yes, good. That's the anterior cut. I'll show you in a minute. Probably see from there, but it's a flush with the anterior cortex. If it is too prominent, take the rinse out, no problem. Cut this one, good. Right hand, okay, go. Just make sure it's flush again with a small blade. It should be flush with anterior cortex. If it is prominent, proud means stuffing of the patella. Patella femoral pain will happen. If it is too much taking, that means it's notching. Notching is good, not good. Take it. It will lead to periprosthetic fractures. Okay, no, I'll take it. So posterior condyle, you don't cut it completely, just stop before the posterior condyle so that you protect the vessels. That's anterior chamfer, posterior chamfers, and this knee has got a trochlear notch. So as you know, some of the knees have the deepened trochlear notch, so that we don't have to replace the patella. Like one PFC, we have to replace the patella, whereas Genesis and this one, we don't have to. Okay, take this one up. Cordostome. So as I said, it's not, we didn't cut completely, but osteotome, I'm completing it. And the trick is, cut it, go little this way, withdraw little, and avoid the posterior condylar friction. If an osteoporotic, you have to be very careful. Okay, now sublux the tibia, as you can see, nicely subluxed. Meniscal holders. Moderate material, but next time get on. Is it? Jagdish Raleigh does. As you can see, there is a significant tibial damage, erosion, where, okay, now tibial jig, you give about 3 to 5 degree slope, and take 9 millimeters from the normal side, okay, and make sure you check it again that you are not taking too much. Probably might need a screw here. You just see, if it is more than a centimeter, might need a screw. And the slope also looks good, and it should be center of the ankle, second metatarsal, just medial to the tibial tuberosity, middle 1/3. Okay, I think that's enough. Fix it. Good. So if I put in the top, I think we're not taking much, so we'll go underneath. Probably I've taken more than 9 millimeters. We'll see. Take it out. Whether we can put a bigger spacer. It was taken intentionally because there's a defect, medial tibial defect. So, okay, good. So back. So make sure it's complete. And double osteotome technique. Put one osteotome on the tibial plateau, with other osteotome you elevate it so that you don't damage the cut surface of the proximal tibia. Cut it. Now take the okay, got it. Not with it. Meniscal holder. Careful. So important, it slips, but it did not damage the tibial surface. So, and you can see, where is it? Forceps. This is entire lateral surface, lateral tibial plateau. This is the medial one. There is not much, and still there is a defect. Most likely we need a screw. Take it out. We'll take the osteophyte out before we size it. Okay, what is that one? Take that one. One. Clean soap. Good. So you always measure the lateral tibial plateau. Little bony prominence is there. Take that one out. 5 EHS. Huh? Okay. This is 5. 5 looks good. And I think the defect is forceps here. Defect is more than 0.5, so we'll use 2 screws. Okay, gone. Hammer. So tibial preparation, finish the సేమ్ వస్తుంది అక్కడ. Good. So sometimes what happens is, because I use a little smaller not tibia, means there is little excess, so I want to take a little bit of this. Huh? Oh, this guy. So posteriorly the osteophyte, I'll take that one out. You have to be very careful, and probably I'll lay off little of. Okay, that looks good. That is, it increases the medial gap. That's a release equivalent to release, which we don't do it. Take it out. Right hand. Ready? Take that one off. Section off. Section of J. Okay. Osteophyte in there. More osteophytes there. This one as well. No? ఇది కొంచెం లేదా రైట్ ఉంది కదా సైడ్. Okay, good. Drill hole is there. Now we'll finish up the femur. Lift up, lift up, lift up. Very good. And the initial indication, lift up. Initial indication is give me an osteotome. Third osteotome, third osteotome. So you can use a tensioner, laminar spreader to see, but roughly clinically it looks medial surface is medial flexion gap is lighter than the lateral one, but we'll see in a minute. I will take the posterior osteophytes, remaining ones. Okay, take this one out. Middle side osteophytes are there. Look at that. That will improve the range of movements as well as the flexion gap on the medial side. Yeah? Okay. A little meniscal piece, meniscal holder. Good, that's no. Okay. Leave it. I do PS knee. So when you cut the box notch, the flexion gap increases by a millimeter. That's the reason I take 1 millimeter extra of distal femoral cut. Okay, Bharat? Good. Meniscal holder. This one. Okay, good. Lift up. See. Very good, very good. Lakshmak Sarastha. Hold that one. That permit to me again. The remaining of PCL is there. So we don't want that one. And some more osteophytes in the back, I think. Okay, this one is all right. And then there. Still osteophytes are there. You have a good colleague surgeon to assist, I think you get better results. So when you start off doing, take your good colleague as an assistant. Okay. So, and then okay, we'll just see the trial, and probably I feel need a little bit of release on the medial side. Corresponding? Good. Okay. That fits nicely. And one more tip before you put tibial insert, just move extension and see. I think there is definitely flexion gap is less on the medial side. Okay, give me 9. So this is a 9 one. Lift up. Okay, going in easily. That's full extension. As you can see, stable only. Looks okay? I think looks good. That looks good. Okay, give me the rod. We'll check the alignment rod. So you can check with alignment rod. See, that's the sorry. Full extension. It's stable. 30 degrees stable and 90 degrees stable. Not coming out. I thought I might use more, but not using it. So that's alignment rod. It should be center of the ankle. Kanpistunda? Center of the ankle. Straight. Camera should be parallel. Very good. So if we drop this one, center of the ankle, you can see here, and second metatarsal. If extend other side, it should be, that's a anterior superior iliac spine, and that's the pubis. So a middle, that's the center of the, so center of the hip joint, center of the knee, center of the ankle. So we'll take the same implants. Looks good. Okay, good. Show me the implants. And screws will be it. It's always important. Show me. Always important to check the implants yourself. So it's a 2 persons checking the implants. So that's a E right PS, size 5 PS, tibia. Okay, good. So make sure you check the implants yourself. Lift up. Okay, good. So as I said, there is a tibial defect about more than centimeter to 1.5 centimeters. So we will hard bone. We will make holes as well as straight one. Small saw. Okay.
Gauze.
We can take up saw little. I think leave it. No. Leave it. This down and so. Okay, that's fine. Bill. So you make. This is what size is? 3.2 కావాలి. 3.2 ఉందా? 3.2 కదా? మరి. Give me this one. We'll make a holes, but for the screws we will use 3.2. As you know, bone should have good porosity to hold the cement. As all of you know, bone cement is not a glue. It holds the implant by interporous bonding, like cement we use for buildings. So we want to use 2 screws, 30 millimeters. This one, 30 mm. There we go. Okay. And the ideal screw position should be vertical. Ideal, but if vertical, this is not possible here. So you can have up to 45 degrees. So between 90 degrees to 45 degrees. If it is transverse, it doesn't support. So in between 90 to 45 should be the ideal. So this going about 30 degrees. Tighten. Tibial tray wall. So you don't have to go completely. Just make sure tibial tray. It doesn't touch the tibial tray when you're putting tray. So it's clear of tibial tray, not touching. Okay, that's good. One more screw. Now one sheet, good, clean sheet. This one. Tighten it again. So that's the management of bone defects. We have large series of management of bone defects. If it is up to 5 millimeters, doesn't touch, little tighter. 5 millimeters you can manage with a bone cement. More than 5 millimeters to 1 centimeter with a screw. More than that you need a wedge or bone graft. Screw out it. Listen to the screw?
Yes.
Good.
Thank you.
So we need a wash out. Wash and clean sheet.
One block.
And the hole should be blocked. So that's about total knee replacement. So tourniquet time is about 22 minutes. Okay. Good. And we have a big team in FRCS Medical College. This is this is a laminar flow theatre. As you can see, the roof, wash it, is with laminar flow. The hood is within the ceiling, it doesn't come down, so it doesn't obstruct any equipment, especially C-arm. And the walls are not stainless steel, they are high density polyurethane, doesn't conduct any electricity, so doesn't damage any sensitive electronic instrumentation. There is no static electricity with this kind of walls. Floor is epoxy flooring and it's a laminar flow theatre of good size. I think for joint replacement knee theatres you need joint replacement surgeries, you need laminar flow theatre. I'll show in detail. Probably take the camera out and show that one. Can you see the ceiling? Ceiling on the top. Yes, the top one. Above the lights you can see the filters, heap of filters underneath, and show that one. Those are the exhaust. Zoom to this one. Zoom. So there is a positive pressure inside. The air will come from the laminar flow top and goes out through the exhaust, and air exchange 20 times per hour. That's how we keep operation theatre sterile. Previously we used to, careful, support the knee. We used to fumigate, which doesn't affect, it's only bad for the staff and surgeon. So stop fumigating. The best way to keep sterile is HEPA filters. And previously we used to worry about doing infection cases, but if you do infected case, keep the laminar flow on for 30 minutes. It gets cleaned, and maybe an hour in case of very severe infection. More, I want more normal saline. And one more key in the knee replacement is pain management, because most of the patients are worried about the pain. So we use, can I cut on that? So it's a cocktail. We'll give the details of cocktail. We inject up to 100 ml into the periosteum, because most painful part is the periosteum where we expose. So like in a horseshoe manner into the distal femur, mix it. Make sure you don't inject into the vessel, and little on the medial side is coming out, okay, and on the back, posterior. So you covered around the femur, which are the important nerves coming for the pain. So this is a rapid, is a part of rapid recovery. We can make the patient stand up after 4-5 hours once spinal anesthesia wears off, and it doesn't affect the muscles. You can use a continuous intra-articular catheter, which is much superior to epidural or femoral block. And whenever you do the little gauze piece so that it doesn't damage the cut one, clean again. So we are ready for cementing. You can see suction, little soft tissue is there, take it out. Good. That's clean enough, I think, no need. Should be clean and dry, as you can see. Ikkada తీస్తున్నావు నువ్వు? ఇక్కడ బ్రెయిన్ ఉండదు కదా. Close, zoom. I think we should do 2 photos. We should do ourselves. This fellow doesn't have any. Ikkada. So that's a canceller screen one. Little cement and screws. Little cement and screws. Small amount. Okay, good. We'll just cover. It's not touching the tibia, but a small layer of cement between the screws and the tibial plate. Take the excess cement out. Little more should go down. Hammer. So that looks good, and the tibial tray is very well covered. So this side I can see the tibial plateau, the other side also looks good. Okay, lift up, clean swab, very good. Okay, sorry. And more little, see this cement is coming out, that means it expands, and tibia also sinking a little bit. That shows there it is under pressure. Femur, little more, lift up, come this side, come etc. Lift up. What happened? Huh? Little lift up, you have to lift up, not lifting it. Yes, that's why. Lift up. Lift up. Okay, no problem. Yes. No, you have to lift up properly. Yes, okay. What's wrong? Wait. Little. Should go. Should not struggle so much. Corresponding? Yeah, that goes. So it's important that good. You should put a holder, then it becomes easy. I was trying to do with a free hand. That's why I think we had a little struggle in putting the femur, but you can use a femoral holder, which makes your life easy. Impactor, little more it should go. Good. Take the excess cement out. Good. 9 spacer. Good. That's a good sound. Did you notice? Good sound. That's the bench. Take it out. So full extension. Little lax. No lax. Looks good. So that's what we want. So it may be 1 to 2 millimeters lax on the lateral side. That's acceptable. That allows little rotation of the femur and the tibia as well. Okay. Omens, excess cement out.
Boss.
We'll take this one out. Okay, that looks good. We'll just make sure, lift up, కొంచెం lift up. Wait. Little cement there. Okay, just make sure nothing in the back. Little dust, stop. Leave. Small mosquito. At this stage you have to be careful. You should not sublux completely because implants are in place. This is the time most commonly you damage the MCL. Wash. So I'll tell you a little trick how to put the insert inside without subluxating the tibia. Okay. 9, open 9. Again, make sure you see yourself. Good. You must clear off all small bone pieces as well as cement, so that third body wear is prevented. So here, I'm not subluxing the tibia, just put it inside, and this implant, okay, draw a little, 45 degrees hammer. I should go in, one in, with, I think that's got come out. So that's in, and it's stable. Okay, come this side. Okay, okay. So that's full extension, and put it, come here. One hand on the tibia, other hand on the heel. Pressure, full, not too much, and proximal pressure. ఇక్కడ ఒకసారి తీసుకురా, కెమెరా తీసుకురా, పట్టేలా చూద్దిరా, చేతిలో పట్టుకో, తీసేసి స్టాండ్ తీసుకో, చేతులు తీసుకురా, అక్కడి నుంచి రా. బెటర్ టు హోల్డ్ ఇట్. ఇది కదా స్టాండ్ కంటే, ఇదా తీసుకురా. వస్తా, అక్కడ వస్తా, ఇక్కడ వస్తుందా, ఇటురా. మెల్లగా జూమ్ చేయి, ఇక్కడ లైట్ కొంచెం తీసేసి. As you can see, patella completely deformed, so many osteophytes. Okay, that's better. See, patella completely damaged and so many osteophytes. So we take the osteophytes out. Routinely, I do not replace the patella unless there is a problem with patellar tracking. Generally happens in rheumatoid patients or post-surgical patients. But whether you replace the patella or not, the reoperation rate is same. So you do patelloplasty. That means you expose the subchondral bone to create a raw surface so that fibrous cartilage will form. Okay, now we do circumcision, peripatellar denervation. We publish this paper in Orthoplasty Journal. It's effective, but you have to be careful not to go too deep and not too much of damage of vascularity. Then you do patelloplasty, expose the subchondral bone. As you can see, that ridge is there, so take that one off, and can you see? Just a minute. Okay, So now so you expose the subchondral bone, made it flat so that it will track without much difficulty. Check that meter. Okay, that looks good. A little piece is there, just expose the subchondral bone, that's the whole idea. Okay, good. So that's about the patella. I'll just show you once the patella tracking. Okay, can you bend it slightly? Bend it. So without support of the, bend it. Without thumb support, patella tracking well. That looks good. Okay. So, Manjunj. Also, stand also, just reach. So, exposure is important, closure also important. It should be watertight compartment of the retinaculum and reconstruction of the extensor mechanism and a closure of subcutaneous of the skin. It will use just for subcuticular. So now we started using subcuticular dissolvable stage, so no clips, no skin clips. That makes a patient very comfortable, because most of the people complain when you're taking clips out. We routinely use clips. Now it helps us creating a water compartment, watertight compartment, as well as prevents the pain of removal of clips. So Dr. Jairam Reddy is going to show you the closure, and the team, big team is here. Of course, the team. Dr. Jairam Reddy is a professor. Show him. What move? I say Dr. Divyana, she is the one who arranged this teaching for you. Dr. Sridhar, sports and knee specialist, joined recently with us, and our Dr. Ayatullah is a professor, anesthesia. Jyoti is our orthopedic nurse. Bharat is there, and I think Lakshmi described, our senior nurse. Come here in the front. Senior nurse. We learn a lot from the nurses, experienced nurses. She's been working with me for the last 20 years. So Jairam Reddy is going to show the closure. So release the tourniquet, wash out, release the tourniquet, then you come this side. Just look at that. Gopal Reddy, baga అయిపోయింది ఆపరేషన్. వీడియో రికార్డ్ చేసిన మొత్తం నీది. చూపించు, అది లైవ్ ఉంది. స్టాండ్ తీసుకొచ్చి పెట్టి వాళ్ళు పెడతారు. నీవి కెమెరా అక్కడ పెట్టు. Take my mic out. Put it to Jairam. Okay, tourniquet release. Okay, I'll come back again. Switch it, step number you. Watching. Hello. And what happens is we keep watching. Not one after.
Now we can share the things so that we can subscribe.
Very excellent. It's a good teaching for everybody. Thank you. Welcome back. Nanu Vidu.
ఎడబెట్టదు ఆడబెట్టదు ఏదంటే అటువై పెట్టుకో
చెప్పొచ్చు కదా ఇంకా చూడొచ్చు మేడం చెప్తుంది మేడం పెట్టాలా మేడం సార్ సార్ పెట్టుకొని మధ్యలో వాయిస్
థ్యాంక్ యూ సార్
వద్దా
వాళ్ళు కంటిన్యూ అవ్వాలి
ఆపారు
నువ్వు యాంగిల్ మార్చుకోవాలి నేను చెప్పాలి
మేడం ఆపారా
నేను కాదు కదా
ఇది
సరే పెట్టుకోవాలి
సార్ పెట్టుకొని రెండు మాటలు చెప్పాలి తీసేస్తా
final thing is I know Guru. Something else is coming.
తీసేదా